for being here. We're grateful for you.
Hi, thank you guys for allowing me to be here. I'm LaRonda Osborne, and I'm the Child Fatality Prevention Review Coordinator here at Tacoma Pierce County Health Department. And I was inspired to do this particular slide after I went to a conference in Houston earlier this year and met some amazing people who helped start and recognize that we need to do something. Something needs to be done about the overwhelming and alarming deaths of African American infants. And so, with me talking to some forensic pathologists and a couple of doctors, I wanted to just bring awareness to some of the things that were being said there in this meeting and where they would like to take things to take a big deep dive into what's really happening. How can we get to the root of the problem? How can we look at a situation and see that something needs to be done? And I decided to do this, and with a lot of research, I'm glad I did because I'm very passionate about our infants because when I do our SUID infant deaths, it does break my heart to have to continuously see the same things happening over and over and over. And it's in my advocacy, what can we do to help? So that's where I want to get started at. Can y'all see my slides, by the way? So the agenda is the
We
history of,
cannot see your slides.
wow, there we go. Let's try that. What about now?
Can see your agenda. Thank you.
Okay, thank you. The agenda is going to be the history of infant deaths and what mechanisms that they used to use as prevention, what was working, what wasn't working at the time, some data behind the deaths, and some risk factors that help contribute to the demise of African American infants, and some contributing risk factors, along with some evidence-based recommendations. So SUID and SIDS affects all people of all backgrounds. It's not just one race, one color, one boy, one girl, one anything. It affects everyone. And throughout most of our human existence, mothers and their infants have shared the same sleeping space with close physical contact. She could provide the infant with needed warmth and nutrition as well as protection from predators. Thus, the practice referred to as co-sleeping was essential to an infant's survival. Babies are still dying, unfortunately, suddenly and unexpectedly. And since the beginning of human existence, these unfortunate incidences were even talked about and mentioned in the Bible. Because First Kings states 3:19, during the night, this woman's son died because she lay on him. And that's just unfortunate. It has always seemed to have been happening, rather in Egypt, Babylon, the Middle Ages, the Renaissance. Churches were beginning to prosecute women, even excommunicating them from churches and having, they had to offer penances. And even in antebellum slavery, Virginia, infant mortality was extremely high in the decades of the 1850s. However, during the most recent millennia change, the ascension of evolution occurred in many aspects of human behavior. As a nomadic life was abandoned, different environments, climates were adopted, permanent dwellings were built, and cribs, primitive types were made for infants to sleep separately from their mother. Thus, co-sleeping became more of a matter of choice for mothers than a behavior pattern required for the infant's survival. However, from the time of co-sleeping, as an alternative practice, it became an issue associated with turbulence and controversy, which presents to the present day. And bed sharing in the non-industrialized society during the 20th century. And we changed the term from co-sleeping to bed sharing, came to replace it because it seemed as more specific to mothers sharing their sleeping space with their infants. So the question of bed sharing has been addressed during the past century from across cultural anthropological studies. These have made available data for many aspects from different cultures, such as physical environment, social and family structure, and eating and sleeping practices. So a lot of the theories were overlaying, smothering, infantile, suffocation by bedclothes, you name it, it has taken on many different terms throughout the centuries. And African American culture still struggle with this practice, and in some cities are still being unjustly criminalized for these occurrences. So back in the centuries, there used to be mechanisms for preventions, such as this arterial co-sleeper. These cradles existed for millennia to hold infants during the day, and babies slept with their mothers at night for the most of human history and still in many parts of the world. So it's a half barrel with all but three slats removed, one on each side, one on the top, and probably the world's first design for nighttime sleep. So it's an Italian name, or Curo is called Little Arch. And for 17th century creation was put on a mother's bed with the baby inside, allowing a baby to sleep and breastfeed through the night without the possibility of rolling over on the infant or having the infant roll out of bed. So it was used somewhat, but it wasn't always the best option. Then, as centuries came, there was bizarre crib patents, co-sleepers, and this one was the window unit. And it first came out in 1919, not long after American pediatrician Luther Emmett Holt insisted in his book, The Care and Feeding of Children, that fresh air is required to renew and purify the blood, and that those who slept out of doors are stronger children. So what city dwelling parents were going to do, why they put a baby in a cage, suspended it out the window, much like an air conditioner unit. And Eleanor Roosevelt used one in her townhome window for her daughter Anna until a neighbor threatened to report her for child cruelty. She said, "This was a shock to me," Roosevelt wrote in her autobiography, "for I thought I was being the most modern mother. Thankfully, we aren't airing babies out of windows anymore. But if you can buy infant tents for nap, but you can buy infant tents for nap time at the beach, something fun and creative." So let's just go with what's happening. During slavery in the US, co-sleeping infants sharing the mother's sleep space has prevailed throughout human evolution and continued over the next centuries. Western civilization, despite controversy and blame of co-sleeping mothers for the death of their infants. During antebellum slavery, Black mothers had no choice but to bed share with their infants because they predominantly lived in a one-room shack shared by up to 5 to 10 people, including adults and children. And without a well-developed field of pediatrics, white physicians had little to offer. Consequently, they often blame enslaved mothers and midwives using harsh gendered and racist language for infant deaths that were more likely as a result of the mother's hard labor and poor nutrition. And beyond verbal attacks, antebellum US physicians also began to use their access to Black and enslaved bodies to expand their scientific knowledge and build their professional reputations. So during slavery in the US, infant mortality is significant high. 30 to 50% of enslaved infants died during the first year of life. And those risk factors were poor nutrition, disease, harsh working conditions during pregnancy, and no access to health care. And this continued throughout history, with 50% of infants died within the first year of Reconstruction during Jim Crow laws. And between 1960 and 1964, Black infant death rate was 1.1 time, 19 times higher than in non-Jim Crow areas. And those risk factors included segregation, cause of racial disparities, structural racism, and criminalization. So you have to ask yourselves, what made a difference? When did things start to change? Associations were explored between the abolition of Jim Crow laws, which were state laws legalizing racial discrimination, and were overturned by the 1964 U.S. Civil Rights Act, and birth cohort trends in the infant death rates, U.S. Black and white infant death rates within this and across sets of states, and within and with and without Jim Crow laws. So the results were between 1965 and 1969, a unique convergence of Black infant death rates occurred across policies. In 1960 to 1964, the Black infant death rate was 1.1 times higher than the Jim Crow policy than in the non-Jim Crow policies were in 1970 to 1974. The rate ratio shrank and to remain at approximately 1 until the year 2000 when it rose to 1.10%. So no such coverances occurred for white and Black differences in infant health death rates for white or Black. So our results suggest that abolition of Jim Crow laws affected U.S. Black health infant death rates, and that the valid analysis of societal determinants of health required appropriate comparison groups. So they needed to compare these groups in order to understand what was happening, why Black infants were dying at a higher, faster rate than any other society of children. So that the difference was the Voting Rights Act. It led to a reduction in Black infant deaths in Southern counties that had severe voter suppression practices, and the Civil Rights Act of 1964, where state Medicaid programs were born, access to health care, economic progress was there. Black women were working now. They were buying homes. They were able to take care of their infants. So we look at some stats. There was a significant drop of Black infant deaths that was reported in 1970 with all of these changes that occurred. So the death rate went from 97.5% of all Black infant deaths until by 1970, it dropped to 19.8% because and I say we, African Americans were no longer in slavery, and those changes during the Civil Rights, Voter Rights Act made those changes, and they reduced the deaths that we had in our community and our cultures. The New York Times had a big front page story about appalling racial gap in infant mortality. Infant mortality in general has gone down substantially since World War II, but the racial gap has actually increased. And in 1950, according to the CDC, the Black rate of infant mortality was 64% higher than the white rate. Today, it's 133% higher. So, and we look at some national vital statistics, and this is the report from July 2024. In 2022, infant mortality continued to vary by race. Infants of Black women had the highest mortality rate, 10.9, followed by infants of American Indian and Alaskan Native and Native Hawaiian and other Pacific Islander, which was 9.06 and 8.50. Hispanics were 4.89 and white 4.52 and Asian 3.51. Infants of Black women also had the highest neonatal mortality rate in 2022, which was 6.44%, compared with infants of other races of Hispanic origin groups. The lowest mortality rate for infants of Asian women was 2.47. So despite a record low infant mortality rate in 2020, a new study found that an unexpected jump in unexplained deaths in Black infants during the first year of the coronavirus pandemic. The rate of SIDS or SUID or sudden infant death syndrome increased by 15% in a single year from 33.3 deaths per 100,000 babies born in 2019 to 38.2 such deaths in 2020, according to the research from the CDC. So we have to ask ourselves, why is this still happening to one group of people? And to do that, you have to look at the root of the problem. Research has documented that social and economic factors, racism and chronic stress contribute to poor maternal and infant health outcomes, including higher rates of perinatal depression and preterm birth among Black women and higher rates of mortality among Black infants. So since the 1990s, research on maternal and infant death disparities has increasingly pointed to structural racism in societies at large as a stressor that harms African American women at both not only psychological and genetic as well on those levels. And conditions such as hypertension, which have been linked to the stress of living in a racist society, contribute to disparities in pregnancy-related complications such as eclampsia. These detrimental health effects on daily life are then further compounded by racial discrimination and a disregard within medical institutions. Black people have a right to be suspicious of an institution that has historically victimized their ancestors for centuries, and it is up to all of us, but especially medical doctors and public health professionals, to decolonize obstetrics and gynecology specifically, and American medicine more broadly, and to apply comprehensive anti-racist policies in the prevention of Black people's deaths. As we can see, the chronic stress, the unemployment, family discord, all of these things play generational trauma risk factors. And furthermore, we have contributing factors. Years of research and news reports have raised attention to the effects of provider discrimination during pregnancy and delivery. News reporting and maternal mortality case reviews have called attention to a number of maternal and infant deaths and near misses among women of color where providers did not or were slow to listen to patients. So a recent report determined that discrimination defined as treating someone differently based on the class, group, or category they belong to due to biasness, stereotypes, and prejudices contributed to 30% of pregnancy-related deaths in 2020. Washington chapter of American Academy of Pediatrics did this wonderful article called Flipping the Script in Safe Sleep Education to Reduce Racism in Perinatal Care. And they did an amazing job with these listening sessions that they did in King County, and they reported the findings. And in these listening sessions, they asked program participants about their experiences in perinatal care settings within large healthcare systems. So the purpose of the project was to share out the lived experiences of families impacted by racism in maternal health and prenatal care in King County. And by increasing the awareness of care providers and leadership in large institutions, the aim was to institutionalize anti-racist and pro-equity practices in healthcare. So some of the contributing factors after they did their research was like not feeling safe with providers, no trust or trust and understanding of cultural upbringing, feeling bombarded with safe sleep information, but do not feel comfortable about having conversations about sleeping arrangements. Health issues were not taken seriously, which resulted in immediate care being ignored, feelings of neglect by healthcare providers, and not a lot of community cultural advocacy. That's what some of them felt that they were dealing with. They also went on to show more evidence-based recommendations, which was great because after listening to all of these parents and these women and these caregivers about the discrepancies and the disparities that they were faced with, they came up with, more evidence-based recommendations, such as continue to investigate the links between social and biological determinants of infant mortality, improve educational opportunities, having trusted sources that Black women, Black families, Black caregivers feel comfortable talking to, economic empowerment of Black families, more jobs, more chances for Black women to create their own spaces and their own jobs and to create their own jobs and businesses to control their own money. Diverse workforce, increasing racial and ethnic disparities among healthcare providers is essential because there are a lot of times Black women will go and try to find Black doctors and it's hard to find in certain areas so they don't feel safe with who they see every day because they feel judged and they feel all of those things that study came out to show. Educate clinicians in historic and current oppressive practices that impact the lives and health of families who are people of color. Because if a person doesn't feel safe, then they don't trust their doctor, then they don't have access to care that they need, which will cause a downplaying effect. And you look up and then we have all of this happening with our Black infants when it could have been resolved from the start at the announce of being pregnant. They should have always felt safe to bring a child into this world. Messaging and education, whole family. When it comes to African Americans, sometimes you have to educate the whole family. I know when I had my daughter, the doctor would tell me one thing, but my grandma would tell me something else. And I always understood that until we also train some of our elders or educate some of our elders about the new standards and how to sleep safely with, not sleep safely, but safe sleep with infants, then we can help. That's a start to help reduce the rise in Black infant deaths. And I hope that this was something that you may have learned something new from today, but it all really starts with how we treat each other and how Black providers, Black mothers, Black parents, Black caregivers feel, so that if we as a system, as a whole, as a society can make small changes, then we can continue to see efforts and ways that we can save lives. Any questions?
That was powerful. Thank you so much, LaRonda. We
Thank
definitely have time for questions and conversation. So please feel free to raise your hand if you'd like to join the conversation. Cheryl.
Hi, LaRonda. I was wondering how I have a friend um, who I think her kids, when they were babies, co-slept with her in the bed, and she, had her husband sleep elsewhere. And that same, when it came to her grandkids, that they did the exact same thing. And so I'm wondering, how do you talk to someone that really believes that co-sleeping's okay as long as the dad or the father is not in the bed? Especially, my friend is Alaska Native, and they too have a high more infant mortality rate. So I was just kind of curious about how you would talk to someone that believes
you.
co-sleeping's okay as long as the dad's not in the bed.
I would
Thanks.
actually, oh, I'm sorry, were you finished?
I'm done. Thanks, Laurent. Yeah.
I would actually, talk to be honest with people, tell them the other side of the situation. If people don't know that there's a chance that the infant can die by doing this, because we're just going to keep going and doing the same thing we've always seen, heard, and done, and we know everybody has survived. It hasn't happened in our family, but what about those families where it has happened? There are cases where sometimes telling their story, another mother or another family member or provider can hear that and say, wow, I don't want that to happen to my kid. And that'll spark them to say, what can I do to prevent that? Because we in our society, we don't like to talk about death. I noticed that, and I've lived and I've worked in death for the last 25 years, whether it's autopsies or donor services or child death. It's always the same. No one knew until it happened. And they would always say, if someone would have just told me that this could happen, I would have paid attention and listened. And being African American, that the hardest thing in the world was trying to convince my grandma that I could not have my daughter sleep on her stomach, because my daughter was born in 97, and that was around the time when um they were transitioning from sleeping on your belly until having us have the child sleep on their back. And my grandmother just honestly wouldn't have that. And I would hear stuff like, well, I had 5 kids and they all survived. And hey, all it takes is one time.
Yeah.
And so once they understand that all it takes is one time, and how detrimental that could be, then they really don't pay attention to that. And so here lately around my neighborhood and people that I know that have just recently had kids, when I go to their house, hey, let's show you how to do this correct way. Take all this stuff out of the bed, stop using it as a clothes hamper. And, they don't need all of this cover and pillows, just little things like that. And once they start to come at me with the whole, well, my grandma did it. And I said, well, guess what? All it takes is one time. What if you lost this baby today? And then once I said that to her, every time I would go back over, the baby was laid down in a safe space on their back with nothing in the crib. And I was thankful that they actually heard me, because unfortunately I had to use the what if scenario. But sometimes they need to hear the truth in order to save themselves.
Thank. I appreciate that. It makes sense.
Cat or Melanie. Well,
Yeah, Kat, I see you put a question in the chat. Do you want to come off mute?
do we have statistics on the mortality of the mothers during the 97.5%?
So that was the 1917 to 1919 era.
I got my statistics, all of those. If you go through the CDC, I just got it straight from the CDC. You can put any year on there. You can even put 1900 or 1899, and they'll give you stats for That's where I got all of my, going back that far is go through the CDC and just ask those specific questions and they'll give it to you. Melanie?
Yeah, hi, LaRonda.
Hi.
I know I'm sure the slides will be sent out. Unfortunately, I was in another meeting and I jumped in probably halfway through your presentation. But that said, I wanted to also just kind of speak to the last I guess comment you made about the grandmothers, and this is what our grandmothers did and our mothers did. It's kind of interesting that, because of a lot of the cultural beliefs in a lot of different, communities and a lot of different community, or sorry, uh, yeah, people of color. I think another thing, perhaps, that, to kind of also flip the script well, our grandmothers did it, our grandmothers said that they did it, but also like our grandmothers were also in a time where people were
Mhm.
still smoking in rooms, in
Mhm.
buildings, people were not wearing seatbelts, people were, so perhaps that, like the learning that we've, learned since the 90s or the 70s or the 80s or whatever it is also sort of part of that equation. It's like, well, just because it was done with our grandparents doesn't necessarily mean it's healthy for now. So, I mean, there's just so many examples of things that, you know, I rode in a car without a seatbelt when I was younger.
Right,
So, just
right.
things like that. So, but I just want to, yeah, appreciate you and thank you for that presentation. So, yeah,
Thank you. Yeah, I
share your
get that.
wisdom.
I get that. And that's part of that cultural competency. Are you willing to ask those questions to find out what this family believes, and then help them understand how to protect their children? And if
Mhm.
you ask those questions, sometimes you may get the answer, because I only know African American culture. I don't know what other cultures do. So as if not saying that they don't do this, if I was a physician or had the chance to really talk to my patients, I need to find out what you believe is the right way of doing things so we can discuss it, have a conversation so I can feel you can feel safe to let me know your concerns or your worries. Therefore, I in turn help save yourself and your children. But I won't know that you believe this if I don't talk to you.
Mhm. Yeah, thank you.
Patricia?
Yes. Hi, Larona. So our WIC office in Tacoma Hilltop
Mhm.
has we oversee a lot of different, families, especially our families that are Black African American in that area. The new generation, what we see is they are more open to listening to the advices. But when it's time for the breastfeeding and to try, we feel like something is in the middle of that transition. They are finally ready to breastfeed their babies. The environment kind of make them change their minds,
Mhm.
right? They listen to their moms, they listen to their grandmas. So any recommendation or a way that we can probably approach, even we're trying to invite grandma and mom to the conversations, but something that we can continue supporting them that doesn't fall on the gaps of the, opportunity for these young moms to, have the opportunity to breastfeed their baby. So something that you probably can share with us that we can utilize in our conversations with these young moms.
Well, just asking them about their beliefs of their parents and their grandparents. You're still an individual. I know I love my grandma and I love my mom to death, but this is still my baby. It's almost like giving her the support, the care, and the what she needs to be able to go to her family and say, as for me and my baby, we're going to sleep this way. They have to be, and I'm not going to keep saying she, I apologize for that. They have to be confident in going to whoever the caregivers are that's helping them, that's they're either living with or they may be getting advice from. But I want to keep my child safe. I was taught how to do it. Erin Suma does a great infant class, not everyone can hear that, but sometimes if you can just get an understanding for yourself to protect your children. Like, I want to know what can I do to help protect my baby? I hear mom, I hear that, but when you express to them how important it is, and to go home and tell mom, go home and tell grandma that things have changed. And I don't want that, that, just information saying that, that if you, put him on his stomach, there's a 50% or 40% chance that it could suffocate. Any of that information, because a lot of times, I'm gonna be honest, again, I can only speak for the African American community because I grew up in one. I was raised by, my mother, my grandmother, and I have a daughter. It's all in what I chose to put my daughter on her back, even though every time I went to my grandma's, she was on her stomach. And I would say, stop doing that. She belongs on her back. And after a while, after she saw that it upset me, then she actually started, when she did keep my daughter again, she had her on her back. And I was adamant about that. This is my child and I want to protect her. So that's just how sometimes you have to have that tough love with African Americans. Sometimes, maybe that's just in the South, but that's how I would do it. If my daughter came to me, I would hear what she had to say. Yes, I may have grumbled and complained, but I hear you. You want to protect your child, and I respect that.
Thank you.
Thank you. Hope I answered your question.
Yes, yes.
Thank you so much, LaRonda. Thank you all
Thank
so much
you.
for the conversation. I just want to put a plug that I feel like this conversation is really connected to the Washington State's maternal mortality review panel report that just came out today. So I've got a link for that in the chat. More to come from the state also. But LaRonda, thank you for your work, and thanks for bringing your research and your messaging and your teaching here for us.
Thank you. I appreciate it.
Thank you, Johanna. So we're going to move on to Wilder, who's going to talk about Taproot. Wilder, are you ready?
I sure try to be. Morning, everybody.
Thanks for being here.
Thanks for inviting me. So this is probably a little different than some of the things you're accustomed to chatting about here. My name is Wilder Cruzan. I live in Kitsap County. I've lived in Kitsap County for about 30 years, and I've worked in perinatal care for about 25 years as a doula, primarily one of the first professional doulas in the county, and helped grow the perinatal networking that's here in Kitsap County. I'm connected with the homeless outreach community in Pierce County. And as a result of the work that I've done in Kitsap, have been invited to help sometimes. And one of the things that I know from talking with people that are unhoused, who are pregnant under.
Can you hear me?
Yes. Hello? All good?
I think that was not about us. You carry on.
Okay,
Thank you.
no worries, no worries. So just a little bit of background about what I'm trying to do here. So working adjacent to the homeless outreach community in Pierce County, I've been invited out by case managers to talk with people who are unhoused, who are pregnant in different circumstances, who are unaware of the options that they have, and who are experiencing pregnancy, birth, and parenting on the street. So I am a person who, if I see a problem and we can shortcut a solution, I sure try to. And I find that works best when we just bring people to the table who have expertise in sort of a collective impact kind of model. So I'm putting together this coalition to get people talking to each other primarily. So if we can go to the next slide. So all honesty, I'm just a person who works on the ground, and there's nothing remarkable about that. It's just, it's what we do in different ways. What I know is that experts are the people who do the work. And so as I'm on, working with case managers and guiding them about, trauma, perinatal psychosis, how to route their patients, how to route their clients for that, how to avoid, the many steps people think that they should go through to get to the end result of care, removing barriers. It's very apparent to me that we have a lot of abundant structures of support in Pierce County. And many of them, as I have started to talk with different organizations that work directly with, work with within the perinatal period, there's not a good understanding of what the barriers are for unhoused people. And so there's kind of a disconnect between the needs on the street and access to receiving those needs, and then being really welcomed when people are able to arrive for care. So I've been working on networking and with outreach community and with perinatal community, and just trying to serve as a bridge to bring people together so we can talk about this more, and just try to see where we can shake things up and make things a little bit more accessible for people on the street. So in February, we're gonna, we had one meeting, and then just with the holidays, I've taken a couple months off, but in February, we're gonna restart these just Zooms at 12 o'clock on the first Friday. Hopefully that's accessible for most folks to just pop in, so we can talk to different organizations or listen to outreachers, share what they're seeing and what they're hearing from people on the street about what they're experiencing, so that we can make more informed impacts and policy back where we go home to. Next slide, please. So this is there's a couple of stories here that are very closely aligned to what actually occurred, but not exactly. So this story is about a pregnant woman who had a toddler, and she was fleeing domestic violence. She was living in her truck in Pierce County. She went to one of the Pierce County hospitals to deliver, and ended up having a cesarean, and then was released back to her truck with her newborn and her toddler in the middle of summer. And so when I'm talking with unhoused postpartum people, when I'm asking them about follow-up care in the midwifery model, you would see a 24-hour visit, a 3-hour or 3-day visit, a 1-week appointment, and a 6-week appointment. So there'd be a lot of follow-up. And in the obstetric model, it is a check-in at some point in there, depending on the practice, and then usually a visit at 6 weeks, where there's a big emphasis on birth control. For people living unhoused, their risk factors of really everything are much higher than just a housed person, regardless of extra circumstances. And so it's not an adequate model to release somebody postpartum and however they've delivered, and then not literally see them again for 6 weeks. And the likelihood they can make that appointment, decreases as they get closer, because the barriers day to day are so great. Next slide, please. In this situation, there was a young father who had the mother of his 2 children show up and say, I no longer want to parent these kids. And he now had 2 toddlers, an infant and a toddler, and had no idea how to parent them. And his community were the encampment that he was living in. So access to parenting, to understanding, safe spaces and sleep needs and all of these things were not accessible to him. And so he was able to get some other support, but it really was remarkable I hear these stories all the time of people who have babies and then don't know what to do, who are offered support from like MSS and Nurse Family Partnership, where we can have people go to them, but sometimes their locations change and the ability to follow through on those visits is not always consistent. So this was a challenge for him to figure out just how to be a dad and how to know temperatures of bottles and have access to safe water and these kinds of things. Next slide, please. So these are some of the major kind of big bucket issues that I'm seeing. Again, I'm not a provider. I'm just a Yahoo doing the work. One of the biggest things is mental health challenge. We're all familiar with the connection between mental health dysregulation and being unhoused and all of those stresses. And the system continues to expect people to find some measure of regulation to be able to come to appointments. When you are pregnant, if you are choosing to continue your pregnancy, if you can't access prenatal care and you then go into the hospital, you're subject to a lot of layers of things that would add stress and trauma to your experience, not only for you, but also the likelihood of separation from your baby, additional testing, a longer stay, intervention from social services, CPS. There's a lot of other layers. And some, those are the structures we have to try to intervene and support families. But there's also a high level of policing that goes on there that makes that a harder thing for parents to try to access. So prenatal care can feel really scary if you are unhoused, you can't shower, maybe you are doing sex work, or you are exposed to or using substances. Knowing that as soon as the system knows about you, you could have your baby taken from you is a barrier. It's just is what it is. I also am employed by the Northwest Abortion Access Fund. And so working not only with birthing families for 25 years, but now working in abortion access. It's been very shocking to me to go work with outreachers and hear that they're not able to talk about abortion. And the federal funding piece, I understand, obviously, but it just never occurred to me that there might be other limitations. I really assumed that outreachers would be making every kind of care access available to people. And so hearing when I talk with outreachers that, most of them are funded by provided federal funding and or religious-based funding, which prevents them from even discussing abortion as an option. When we, daily are seeing people who are in sex work by choice, in sex work because they are being trafficked, who are in domestic violence situations, who are assaulted, who are, 14, et cetera, who are not being made aware that they have pathways to access abortion care should they desire or need that. And so abortion funds, if you don't already know, the Northwest Abortion Access Fund serves Washington, Oregon, Idaho, and Alaska. And we provide funding for procedures in all trimesters, and we provide travel funding. So if somebody were to be outside of gestational limits for Washington State, we can get them to Portland, to OHSU, so that they can have abortion at the whatever gestation that they need it. So it's important for providers to know that abortion funds exist. And I'm always happy to talk more about that if anybody wants to know more about that. But that does remove, yes, nwaaf.org. I'll put it in the chat in a second. But yeah, there's abortion funds in every state, and Idaho is one of our states, and obviously it's very hostile to abortion seekers. So we are moving people out of Idaho to shield states for their abortion care and then back again. And we provide funding for hotels, flights, groceries, prescriptions, childcare, ferry tickets, whatever. So get familiar with abortion funds if you're not already. And again, happy to speak more about that. Transportation, in the city, bus lines sound really nice. But if I live in the woods. If I was struggling out here for transportation, it would be very impossible to get anywhere if I didn't have money. So transportation is difficult. If you can't leave your things, people can't leave their tents where all of their belongings are, their family pictures, maybe the only ID that they have is in their tent. And if they leave, often those things are stolen. And so it makes them very hesitant to leave all their belongings behind, or they then have to pack up everything along with their children in order to go to appointments. And then access to hygiene, nobody here wants to go to an appointment if they feel like they are unshowered or unkempt. And we will always shower if we know we're going to be getting naked in front of a provider. That's pretty a standard privilege that we have if we can. It's not any different for unhoused people. We know if we smell bad, and we know if we're in a group space that people know that we smell bad, and nobody wants to have that experience. And so not having access to showering before an appointment, laundry services, trying to keep your children clean so that you don't draw attention to them as neglected. All of those things are barriers that are very easy to intellectualize. But when you go out and you see people who are just so desperate for anything, but they have all these layered things in front of them, it's devastating to think that what's so simple for us as a housed people is an impossible thing to surmount for someone else. And then when we get them into the system of care, it's not going to be kind to them more often than not. Next slide, please. So here's just a few more barriers I wanted to pop up. Before we, hold on, don't go further yet. I just wanted to say, I'm hoping this elevates just a little bit of awareness, but also I'm super excited for any comments or pop-ins or your own reflections about any of these things you've seen, questions you have. I'm not looking to talk at you, but with you. You're the experts of the work that you're doing, and I'm just literally trying to build bridges. So if there's anything that anybody wants to throw out comment-wise or in the chat here, please, I encourage you to do so. So not having insurance, the perception that you can't get care without insurance. But also medical, the medical world in the United States without insurance is a short road to bankruptcy for really anyone. And so if you don't know there's access to low cost, low barrier, or even no cost care, if you don't know it's there, you can't get to it. And so thanks, Jax. It's important to be talking with outreachers to let them know on the street so that they can give that information to folks out there. So just go ahead and roll through the next, all of these little pop-ups that are going to come up. I think that's all of them. So this is the next part of that person's story who was sent back to her truck. Outreaches were able to make contact with her, and they were able to get her into motel shelter with her newborn and her baby, and they were able to get some provider care for her. So she's doing much better. She's not, I don't know where she's at today. Once we move them through, we don't always know where they end up, but at least she was able to not continue her postpartum journey on the street for at least a little while. Next slide. Thank you. And this fella was able to actually work with street outreachers who came together. He would come in for appointments, and the outreachers would spend time with him, educating him and bringing in people who could do some outreach and some parenting support for him to give him some skill building as well. And these were the two cases that really brought home to me that we can do better. We need to, people want to be good parents, and they want to end generational harm of homelessness, and they want to just have all of the dignities that we enjoy being housed, and that we can really make an impact by just supporting people in this really delicate time of their lives. So thank you so much for your time. Any questions?
We have time for one question. And also, Wilder, there was questions about how to get connected to Taproot. So please put website and contact information as you're comfortable in the chat so folks can stay in touch. Kat? Kat, do you want to come off mute and ask your question?
I think, unable to unmute. She's in a call center, I think.
Oh. You're welcome to put your question in the chat.
I see a question from Myra about WIC. One of the really cool things is community referral. So like Nurse Family Partnership allows anybody to make a referral to them. The person can self-select to refer themselves to Nurse Family Partnership. Most unhoused people do have access to a phone because there's services that provide them free phones and then can give them some minutes. And so sometimes in shelter spaces, you'll see somebody making those arrangements. And so it's really common that people can either have a phone of their own or can access somebody near them that has a phone. So that's helpful. Coalition Open to Counties. I'm starting in Pierce. I'm going to move next to Kitsap. These are the communities I know the best. My hope is to expand it out for sure. And I'm open to having that conversation. Absolutely. So I'm currently working on building a network. My intention is to then actually work on an easy access clinic out of St. Vincent de Paul in Tacoma. They just opened a family day shelter that has showers and kids can be there. It's for families. And so what I want to do is bring providers together to actually do an easy access clinic so that people can come in and get documented some prenatal care, some access to options, and maybe some well baby checkups. So that's the next level that I'm taking Taproot to. Until then, I'm making connections on a one-to-one basis. As I'm called into support, I refer wherever to all the resources that I possibly can.
Kat?
Yes. Can you guys hear me?
Yes.
Okay, wonderful. So I've been in contact with a participant in WIC. I have a list of resources that I've just been passing to her. She's currently living in her call and is about to have a baby in a couple weeks. I have given her as many resources as I can think of, step by step, the Share and Care House, um, black birth, and no one is returning her call. Does anyone know a place that can get this mom out of uh, her call and into a warm place so we don't have an incident like losing her baby due to it being cold outside or, you know, poor living conditions?
I would, if she were my client, I would send her to St. Vincent de Paul in Tacoma on 56 or to the Family Resource Center they just opened up. It's expansive case management beyond just housing. It's all kinds of services. And so they also provide some motel shelter as well. That could go up to, I believe, 30 days. And they have to work with a case manager while they're in shelter. So they're frequently having check-ins and goal setting and that are based on that person and their individual structure, like support and their capacity, not sort of like an algorithm of checkboxes. It's really stellar care. So that's where I would start them out. Let the experts do the work of finding them housing because they're also going to know housing might be, there might be shelter on a website, but it might not be appropriate for the person for different reasons. So if you have a trans client, for example, they're not always going to be, or a youth, they're not always going to be comfortable in just any shelter option. So if we can give them more targeted support, they're more likely to accept it. And then, yeah, Pierce County also has a list of perinatal providers and homeless shelter also that talks about like family services. I think I actually have a link up here I can throw in the chat.
Thank you
I will
so
find
much.
that. Mhm.
Thank you. That's incredibly powerful. Kat, thanks for asking your question. And please feel free to keep using the chat to connect and get connected to resources and ask this broad, well-resourced community for suggestions and support. Wilder, thank you so much for sharing this work. It's really powerful, and there's a lot of enthusiasm among this group to support. So thank you, thank you. I would like to connect you all to Sophia Moreno from Global Perinatal Services. Sophia, thank you so much for being here.
Yeah, thank you for having me. My colleague Akua is also on the call, and she is our doula program manager. So if some questions come up, we can tap her in as well to help answer some of those. But I work for Global Prenatal Services as their director of programs. And one of our goals is that every mother and baby survive and thrive through pregnancy, parenting, and beyond. Our mission, if you can go to the next slide, is to create culturally responsive pregnancy and parenting experiences for Black immigrant and refugee families. And we do that through a variety of services that we provide both out of our offices in Federal Way, but then also throughout King and Pierce County. So our doula services, we have birth doula services that are more of a short-term service where we match folks through referrals with our doulas, usually by language and culture and geographic location. We typically start support in their third trimester and go through 3 months postpartum. That has changed a little bit now that we're able to bill through the Healthcare Authority, Provider One, and Medicaid. We are able, depending on the client's need, to not only stretch their time of eligibility into postpartum even longer, they are eligible for within the first year the baby is born. But if they max out their units that their coverage would typically cover, we do have the opportunity to apply for additional hours so that we can continue those services. And those services that justify that extension fall under a few different categories. So it can be maternal health, it can be the birthing person's mental health, if they've had a C-section, additional medical care needed, additional support needed for lactation. If there's a complication with the baby that was born, such as like a tongue tie, being born prematurely, and things like that, we can apply for even additional support as a part of the birth doula program for our Medicaid clients. We also have a long-term doula program our community-based doula program, and it's offered to women around 28 weeks. And they also work for an entire year after the baby is born, to provide doula support. That looks like case management, helping provide baby supplies, and really, it's a very broad spectrum of services they provide. We've had our community-based doulas help folks apply for their green card, help get bank accounts set up, teach folks how to use mobile banking, all kinds of different things. It's really needs-based, based on the particular client for up to a year after the child is born. We also offer a postpartum doula program that's up to 24 hours of support for families from newborn to 6 months. We recently have gotten into some hospitals for a service we're doing called Doulas on Demand, where if someone comes in, is in triage, and in labor, and decide they want a doula in that moment, they'll call us and we will go into our network of doulas and dispatch a doula to support that person in labor. And this is an area we're also thinking that maybe the postpartum doula support for that 20 hours could come into play. If someone, this can be additional to someone who's already receiving services, but it can also be for someone who maybe has not had that experience of the doula support in their prenatal period, but they have that baby and they realize they are really, wanting some additional support. We match, like I said, based on shared language and culture, and we currently offer services in 21 languages. I've listed a few of them here, but we are constantly looking to expand that based on the needs we see through referrals, based on geographic location we see needs arising in. So as ECUA kind of goes through and looks at the referrals that are coming in, if we see gaps in the staff we have to provide services and a need that we're not able to meet, we go into our various community resources and try to find someone, or folks in the community who can work with us and help provide those services. Next slide. So one of our services is lactation support. So we have in-person and virtual. Um, we will do in-person drop-in on Tuesdays and Thursdays at our Federal Way office. We always have someone here 9 a.m. to 2 p.m. We have an IBCLC in our lobby who is available to help folks with any lactation support, any lactation needs. We can also do Zoom appointments if those are requested in advance. And then we have a lactation hotline that you can call or text Monday through Friday, 9 to 5. And if you call and leave a message or you send over a text, then you'll get a response within that Monday through Friday, 9 to 5 time frame as well. We do free childbirth education classes. So they are 3-part sessions. They are free. They happen the first 3 Wednesdays of each month. And so those are also held at our birth center location in Federal Way, 6 to 9. You can see what the classes entail on this slide, and there's also a QR code here where it's a link to sign up. And yeah, they happen chronologically. And I think Makeda, the person who is the facilitator, if you miss one, we're flexible on people, re-signing up, depending on, how close they are to giving birth, to come in and kind of make up classes and sessions as well. We do have an easy access clinic, again, based in our Federal Way location. It was the first of its kind in Washington State, and we provide pregnancy and women's health. You can see all of the list of services we have here. This is also a way for us to refer to lactation, those childbirth education supports. We can do referrals out for ultrasounds, and then our doula supports and the support groups we offer as well. We do have drop-in hours, and you can schedule an appointment at the Setmore link that's linked in the slides as well. We provide some case management and support groups. So, as a part of our case management, we offer these, and I can send out additional eligibility information if folks are interested too in some of our brochures that we have for the various programs. But for case management, it's the doula services, childbirth education. It's kind of like a wraparound. It's your go-to person who is going to make sure you get into all the resources we offer internally, but then also help you navigate any other resources you're looking for externally. And eligibility for that is our African American community, East African community, and Afghan communities. In addition to those, we do run 3 support groups. These happen monthly. So we have a mom's corner. We have guest speakers, a variety of guest speakers who come in and discuss various topics for our birthing folks to learn about. We have a father-to-father support group, which is a similar but differently targeted community, and then an Afghan Sisters Corner to share resources, ideas, and again, learn from a variety of speakers. We also offer a doula certification. So our founder is an executive director is a midwife. She actually owns the birthing center that's attached to our office space, and she certifies doulas. So we specialize in certifying doulas not only locally, but since it's a virtual option, we can do it globally across different states as well. It's a pretty straightforward process. It's a combination of Google Classroom and virtual lectures and kind of classroom setting. We are currently offering the birth doula certification. It'll be about once or twice a year. We just finished up a session, but our goal for next year is spring and fall. And there's a link to our website to get more information on that as well. I know that was a lot. I will say the majority of our clients that we are serving through our birth doula program are Medicaid eligible. That has been huge with the HCA coverage that we have in Washington now for doula services. But we do take folks who are not on Medicaid, and we are also working and hoping to be getting contracts with private insurances as well. But I would say about 90% of the folks we're serving are Medicaid recipients or recipients of other, oh, thank you. I could just put the referral link in there, of other services such as, WIC, SNAP, etc.
Thank you
I'm
so
available for any
much.
questions.
Um,
Yeah.
just for time's sake, I'm going to ask that you take questions in the chat. I'm so sorry.
No, totally fine.
And the work y'all are doing is phenomenal and powerful. And thank you so much for being here to present. And Akua, thank you for being in the background, helping make sure folks can connect families to your services. So if you have questions for Sophia or Akua at Global Perinatal, please put them in the chat. And what we're going to do now is we're going to shift over to talking about the committees for this coalition. We're going to start with Chris Laddish from the Bessler Center, who is our board liaison to our WIC committee, who will be sharing some recent work that she helped facilitate and organize. Chris, are you with us?
I am with you, and also
Yay.
wondering if I can screen share, if that's okay.
You may. I will give you power.
Okay. Let me find my slides here. Let's see. Okay, let me open this up. Content only. All right, we'll see if this works. All right, I'm going to do from the beginning. I may not see you all, so if hands get raised and whatnot, let me see. Oh, from current slide. Are you seeing it in slide? There you go. You seeing this in slideshow mode?
Right now we are, yeah.
Okay.
Thanks so much.
Yeah, you bet. So, hello everybody. I'm Chris Laddish. I represent the Bessler Center at Mary Bridge Children's. We're a community health impact program, and I have had the opportunity to engage more closely with WIC of late, because maternal and infant health is among our priorities. And what I'm going to talk about briefly is just standing up of a WIC formula task force, some lessons learned, where the task force is currently. Many of you may know about it, some of you may not, and I welcome questions at the end. I know others will be presenting, so I won't take too much time here. So overall, in terms of introduction and context, I'll talk about our problem scope and what was going on at the time. With the government shutdown, there was a threat to the benefits for families that were served by WIC. And we quickly stepped up a task force to really look at where we might offer supports to our most vulnerable infants. Our concern was around their lack of having access to formula when benefits were lost. And in our county, we've actually had 2 to 3 other crises, including COVID, the formula recall emergencies, and other things that have impacted formula access for families. So our assessment was that there were 1,850 infants that could potentially be impacted. And we pulled stakeholders together throughout the community in our county actually, to look at how we might address the needs. The interesting thing about this was that it was really largely planning, because as you're all aware, the government reopened. But while we were planning, which we spent around 6 weeks, which I was incredibly grateful for the lean in, using sort of a modified incident command structure. And we had 3 key groups: funding and procurement of formula, distribution of formula, and a communications group to work with families in our community-based organizations to make sure that there was alignment. Our objectives as we were working together were to provide access to formula for all our Pierce County infants that were at risk of losing it, ensure situational awareness of local formula resources, assure effective distribution, communicate with families, involve our trusted partners, and really do this in an aligned fashion. And we're sort of now in our last bullet points there, adapting to where we are currently and really trying to document some fantastic work that happened. As is usually the case in Pierce County, when you ring the bell, friends come running. So we had many agencies that leaned in, which we were incredibly grateful for. And I'm quite certain that this is missing many. I will say that our face-to-face meetings on Zoom involved anywhere from 20 to 30 participants steadily, and we were meeting twice a week. Our distribution list was at about 60 engaged partners who were keeping notified in the wings. In terms of sort of what the assessment was, this is a little bit redundant. I won't read it to you. What we know is from the past emergencies, we had infants that were suffering from dehydration, malnutrition, and utilizing emergency room services to get those issues addressed. Some were even just showing up into the emergency room to access formula. We also had shared from our WIC partners that families were calling with some gut-wrenching questions about things like, what's the least amount of formula I can safely give my child, in anticipation of knowing that formula was going to be in short availability. Looking at our partnerships, we used a collaborative framework, involved many partners, as you saw on the previous slide. And I think this is probably the material that's most of interest, and I think, really is a kudos and a shout out to all of you and to all of our partners within Pierce County. We were able to rapidly step up a donation portal, and we're able, through just small donations, to get approximately $10,000 in funding donated. Our goal was to raise enough formula to support the infant needs for a month, as we were hoping that the government shutdown would not last longer than that in terms of when benefits would run out. Fortunately, we did not need to lean into further funding, but are holding on to this funding at this point, hoping to develop a 1 week's emergency supply that would be immediately available. In this particular case, we worked with multi-care procurement because multi-care serves infant formula needs. And at the time that we were assessing this, had or quoted to us about an 80% cost discount rate, which was a dramatic help, which over time we learned, due to the volume we would have needed, was not going to be accessible to us. So I'll talk about that when we talk about some of our challenges. We were able to leverage the Multicultural Center for Child and Family Hope, diaper banks, our libraries, and many other community supports around how we would use our distribution. And there was a ton of resiliency and adaptability from our partners as we continued. As you'll all remember, this was a constantly fluid situation where, you know, day to day, week to week, we weren't sure if the government was going to reopen or not. In terms of looking at challenges, so as I mentioned, there were some funding sustainability challenge. We found out midway through working on this that where we had been led to believe we would have an 80% cost savings, it came in closer to 18% cost savings. The number that we were working with was roughly $250,000 to feed all formula-fed infants in Pierce County on WIC for a month if you did one-to-one replacement for the formula types that they were on. Another challenge we had was accessing emergency planning. Because this was not a formal crisis, but we were planning for an impending crisis, I learned very quickly that there's a lot of ins and outs in terms of what hits the threshold and hits the trigger for crisis services and incident command structure to be available. In the future, we will be working with our incident teams around how we might access them more quickly and what their needs and thresholds are for getting involved. We also kept a close eye on geographic disparities. Areas that were outlying, like Eatonville and Graham, it was identified had further outreach challenges. And so we were working to try to get formula to them. Lots of opportunities for systemic improvements. I will say that we were excited to have legislative advocates involved, 2 legislative offices. At the state level were involved, several city government officials were involved. So we had nice lean in there to help us address this crisis. So in terms of next steps and where we are currently, we're in the process of doing an after action review, kind of compiling all the lessons learned. There were a lot of really great things that came together. We leveraged technology. We had a geospatial map created that was active, that would allow an individual to highlight an area, learn where the distribution site was, what its hours were, et cetera, which we never had to put into place again. But recognizing that having something like that stood up within 6 weeks was fairly monumental and was something that we could lean in and share with others were a countywide crisis to come up again. Again, we're looking at establishing a small emergency formula reserve closer to a week's time. Shelf life for formula is roughly 2 years. We would likely keep that at the food banks, and we're actively looking at how we can get funding together to have that ready for use were we to have a large recall or an event. And of course, that involves advocacy for the funding. Beyond that, I would say the other thing that I would share is just the tremendous gratitude that I had for the teams that leaned in and supported and showed up on an ongoing basis. I think that we will be sharing and distributing our after action report when it's completed, as well as it'll have a thick appendix of the documents that we created that will be available for others. Related to WIC overall, I want to make sure that the most important note that everyone hears is that while there was a threat of benefits being lost, benefits were not lost. We did have, I believe it was 5 or 6 leaders at the state level that were furloughed early on with the government closures who are since back at work. In the short term, there was loss of things like statistics and epidemiology and the lean in that we would usually use to support and address a crisis that we would not have access to. But families continued to have benefits, and most importantly, benefits were not lost to families during that crisis. There was also closure of one agency statewide and the threat of closure of Spokane, which would have impacted 10,000 families. But that did not happen, and all agencies are up and running and fully staffed, as I understand currently. And if I'm wrong about that, any of my colleagues from WIC can chime in. The other thing that's been shared with me recently is that there's been an announcement mid-November about clarification around public charge, which refers to the component of immigration law that allows federal authorities to deny legal status to individuals that are determined to rely on government assistance. This ruling does not impact WIC. It did not impact WIC, and the state WIC grouping wants to be clear and assure that this statement that they've put out is shared with all, that WIC is not and has never been a factor in public charge determinations, that the proposal that it put out does nothing to change that. WIC remains committed to serving all eligible families and helping them thrive, and all offices are open at this time. So that is my summary. If we have time, I'm happy to answer any questions that people might have, Jax, but I will rely on you for that.
I'm so sorry. We do not have time for questions because we want to present the other committees. But I am so grateful for the work that you led, and so many of you on this call were part of that work. So thank you. And please do connect with, can you go back to the WIC slide just quickly, Johanna, please? So if you want to get involved in WIC meetings and join the WIC committee to support this kind of effort, the meetings are quarterly. The next meeting is March 16th at 9 a.m. And if you want an invitation to that meeting, please reach out to Chris. Her information is here on the slide as well as in the chat. Okay, next slide, please. Erin, will you give a brief summary of what you all are doing with Safe Sleep in Cribs?
Absolutely, and I promise to keep it brief. I know you have. Uh-oh, am I frozen?
Nope,
Did you hear
you're
me?
good.
Anything?
We're good.
I'm back.
We
Okay,
can hear
good.
you.
Apologies. I just want to share just a brief bit about our Safe Sleep and Cribs Committee. We are a committee that is unfunded and unstaffed. It is just kind of those of us who are passionate about infant mortality and involved in the PCPC have come together, and we raise money for to purchase cribs, and then we have organizations within the PCPC. A lot of you, and there's a lot of familiar names on the call today who know about this, but you guys can be a part of it. You can give out our cribs to your families. If you're not involved and you want to get involved either on the committee or become a crib partner, my contact information is right there. arsuma@multicare.org will get you to me and we can talk more. But just for those of you who know what we do, because we've been in place now for 12 plus years within the PCPC, just give you an update for 2025. Okay, so in 2025 so far, our committee has raised $18,800 to fund our cribs program through multiple small grant opportunities locally. We've purchased 115 portable cribs and crib sheets. We have 10 active crib partner agencies within the PCPC who distribute our cribs to the families they serve. And they have distributed already 93 of those cribs to their expectant and new families who cannot afford a safe space for their baby. To add that on to everything since we started in 2013, we are at almost 1,500 cribs that have gone out through the PCPC that time. So a good, fun milestone. We also require our PC crib partner agencies to their staff who participate attend an annual kind of update on safe sleep. Each year, people have attended one of our 4 trainings this year on safe sleep. So that's my brief version, Jax. If anyone has questions, I'll take them in the chat, and I'll let the next committee move on.
Thank you, Erin. Your sound interrupted, but I put your notes in the chat so no one loses the phenomenal work you and this committee have been doing. So thank you.
Thank
Their
you.
next
Sorry
meeting
about
is
that.
tomorrow.
Yep.
Please join them tomorrow if you're interested. Reach out to Erin for an invitation. Patricia.
Yes, thank you.
Thank you. Please be brief.
Yes, no problem. So we are preparing 2026 now with our starting quarterly meeting in January. So highly recommend and encourage organizations that would like to participate in our coalition to join us. This year we are talking and elaborating and planning 2 big topics. First, of course, is the 2026 annual breastfeeding virtual conference planning. And also we want to also to create something like an emergency preparedness lactation support guidance for the Pierce County. So there are 2 big topics, and we definitely can go more into on those topics in our coalition meetings. I know I don't have a lot of time, but I'm gonna leave on the chat my information, how to contact us, and how to be a member of our coalition. Thank you.
Thank you so much. That was wonderful. Our next presenter is Robin. Oh, we went far. Just one pack, please, Johanna. Thanks. Okay, Robin.
Hello, everyone. I just want to say at our First Steps Committee meetings, we get an HCA update, and it's great to know what's going on. We also really love to collaborate with other programs. We have people from Black Infant Health, from Nurse Family Partnership, from Family Connects and WIC. And so just the coordinating together to help service the families better when we know what each other are doing and just work together. We only meet 3 times a year. Our next meeting is February 18th. Please let me know if you'd like an invite. And we'd love anybody to coordinate and work together with us and want to know what more First Steps and Maternity Support Service and infant case management does. Thank you.
Thank you, Robin. Appreciate you. And our education committee, if you would like to get involved, we plan our conference, our annual conference that's in October. We will reconvene our meetings in April. They will be planned around the education committee members and your schedules. And so we would really love more people involved in this to help us plan our conference. So you can reach out to me and I will put my email in the chat if you would like to get involved. Next slide, please. So thank you so much for joining us. Thank you especially to our incredible presenters, LaRonda Wilder and Sophia. Thank you to our board liaisons for presenting about your impressive committees. And thank you all for being really engaged in what a great conversation we've had today. We've used every second together and it's been really wonderful. So thanks for being here. Please go ahead and give us feedback about how we can make this better for you. But we really love and appreciate being a community with you. And everyone is doing such phenomenal work. So thank you for the work you're doing in protecting families. I hope you have a great rest of your day and a beautiful end of the year. And we will see you again in March.
Thank you. Are we able to get a copy of the presentation?
The presentation is posted to our website at tpchd.org/PCPC.
Thank you.
Thank you.